A research study in 2004 by Baker Norton reported that there was a range of 15,000 to 24,000 avoidable deaths in acute care hospitals in Canada each year.
Of those, 1 in 9 are medication errors, and that again is a huge issue, both in the acute care, but we also know this is a problem in the community and in long-term care and nursing homes.
Good afternoon, Millie. I have your pills.
Millie Gold is an 88-year-old resident at Baycrest Long-Term Care Facility in Toronto. She takes several medications a day for a variety of ailments. For many residents like Millie, the interactions between those medications hold serious potential risk.
In an average nursing home of perhaps about 100 beds, you would expect to have about 9 adverse drug events per month, and about half of these would actually be preventable. About a quarter of people in long-term care take over 10 medications, and there's a pretty large percentage of people that take actually over 20 medications.
And that represents a potentially huge patient safety concern. That's why in 2004, Baycrest developed Canada's first physician drug order entry system with clinical decision support for the long-term care setting. They created it based on original research.
And I think one of the things we are able to do with our research is to help people recognize when an adverse drug event occurs. If it's not recognized, it's not counted. And if it's not counted, you can't fix it. What we found out was that adverse events were much higher than we actually thought. In fact, about 5 times higher than had been previously reported.
I think we saw that, in fact, we were making more medication errors than we actually thought. So it was a little bit humbling. You always think about other people making mistakes, but if you're just careful enough, it's not going to happen to me. But in fact, we all saw, I think, that we are as capable of making mistakes as anybody else.
To help physicians make better decisions, Baycrest developed a set of alerts for the most common adverse events. The system is easy to follow. Alerts flag doctors at the prescribing phase, everything from allergies, drug interactions, and potential side effects. And it's constantly updated to keep everyone on top of the most current information. Further increasing the power of the system is the integration with the patient's electronic record.
The information is available at our fingertips when we need it, so I can immediately get the patient's weight and their height and their renal function at the time that I'm trying to prescribe the medication.
The system is accessible through rolling computer terminals and laptops throughout the facility. Doctors can also access the system from home.
I was on call last night and I was able to access some information that really helped me to make a better decision, I think, about the patient, because I could get into the chart and check on blood work and check on a cardiogram and really, I think, choose differently than I would have if I hadn't had access to that information.
The system enhances patient safety because we might pick up an error faster than the pharmacy, or the pharmacy might pick up an error faster, so that we're collaborating with the pharmacy so that we're making it safest for the client.
And that's important to clients like Percy Levy and his family.
I feel very strongly that only the best practices have been introduced. And it helps me sleep at night.
And for the hundreds of thousands of adults who are in long-term care facilities, these systems are crucial for improving patient care and safety. But there are barriers to putting systems like this in place, specifically time and money. For Baycrest, it represents the investment of more than $500,000, years of research, and ongoing IT implementation.
I think that Baycrest initiative is an incredibly important initiative because it shows us the possibilities of how information technology can improve patient care. And those lessons can be taken across Canada. That's going to take money, it's going to take political will to find that money, and it's going to take leadership from our senior administrators.
As a council, we recognize that we need to get physician order entry into all of our institutional settings and beyond. What we also recognize is that we need to build a solid foundation for us to be able to advance these.
Certainly at the early stage it is difficult. I guess what we really hope is that through a lot of the work that's been done here, it's going to be much easier for people that follow in our footsteps.